Hello everyone, welcome to Pathomat. Today let us study about the clear cell variant of renal cell carcinoma. Before we discuss about the clear cell variant, let us have a brief discussion about the renal cell carcinoma as such. The renal cell carcinoma, it is a malignant neoplasm of the kidney. They arise from the renal tubular epithelial cells. That means, for example, this is the Bowman's capsule, this is the PCT, you have this loop of Henle, your DCT, and these are the collecting ducts. So this is PCT, loop of Henle, DCT, and the collecting ducts. These renal cell carcinoma, they arise from the tubule epithelial cells. The epithelium lining the tubules. These carcinomas arise from the epithelium lining these tubules. It can be either from PCT, DCT, or the collecting ducts, and it can be present either in the cortex or the medulla. So these contribute to 85% of adult renal cancers, and they are more common to occur in elderly. That is more common between the 6th to 7th decades of life, and it occurs more commonly in males. That male to female ratio is 2 is to 1. They have a preponderance towards the males. The variants of RCC are the clear cell variant, which we will study today because it is the most common variant. So it contributes to about 70 to 80% of the cases of RCC. And the second most common is the papillary variant, which contributes to almost 15%. The chromophobe variant almost accounts for 5% of the cases. The rarest variant is a collecting duct of Bellini. It almost less than or almost 1%. Other variant is the XP11 translocation variant, which is more common to occur in the children, infants, or young patients. It has a predilection for the young children, young patients, and it is also called a pediatric RCC. This is called a pediatric RCC. Here you have features of both clear cell and the papillary. Hence, it is also called a clear cell papillary variant. Other variant is the medullary RCC, which you find in the sickle cell trait patients. Sickle cell trait is a heterozygous form. That is, the hemoglobin you have one allele you have adult hemoglobin, the other allele is the sickle hemoglobin. That is a sickle cell trait in which you find this medullary RCCs. The risk factors in general for all the RCCs are, in sporadic cases, are the tobacco smoke. This is the most important significant factor, most important significant risk factor for RCC, tobacco smoke. Other lifestyle factors are obesity, hypertension, more common in women. Unopposed estrogen therapy in postmenopausal women can also lead to RCC. Prolonged exposure to polycyclic hydrocarbons. Polycyclic hydrocarbons again they are found in this smoke, tobacco smoke, coal tar, and heavy exposure to heavy metals like occupational hazards like lead, asbestos, and petroleum products. All these are the risk factors for RCCs. The genetic causes are individual for each variant. Now, let us study about the clear cell variant of RCC. It is the most common, almost 70 to 80% of the cases of RCCs are clear cell variant. They are more common between the ages of 50 to 70, and obviously, males are more commonly affected than the females. So, where is the origin of clear cell variant? Clear cell variant, it arises from the proximal tubule. For example, this is the nephron, this is the glomerulus, this is the PCT. From the epithelium of the PCT, the clear cell variant of RCC arises. So, the origin is from the proximal tubular cells in the cortex. This is the origin of clear cell variant. Coming to the genetic causes, 98% of the clear cell variants, they can be both sporadic or familial. They are associated with the VHL syndrome. VHL syndrome is the von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome. In this syndrome, there's loss of sequences on the chromosome 3p, that is the short arm. This is the short arm of chromosome 3. There's a loss of sequences on this. The short arm of chromosome 3, it carries a gene called VHL gene, the von Hippel-Lindau gene. So mutation In the clear cell variants, they're most commonly associated with this loss of VHL gene or the mutations of this VHL gene that is present on the short arm of chromosome 3. The VHL gene, the normal function is it regulates the expression of vascular endothelial growth factor, which is necessary for angiogenesis, and also insulin like growth factor 1, which are required for cell growth, normal cell growth. And also, this gene it encodes for a protein that degrades hypoxic inducible factor 1, HIF1, which is hypoxic inducible factor. Normal VHL gene it encodes a protein. This protein degrades HIF1. When this VHL gene is mutated, it leads to it leads to accumulation of HIF1 because the normal function of VHL gene is to encode a protein that causes degradation of HIF1. When this gene itself is mutated, this HIF1 gets accumulated. This HIF1 it leads to uncontrolled cell growth that leads to cancer, and also they overexpress VEGF, the vascular endothelial growth factor, that promote angiogenesis to support the cancer development, and also it increases the expression of IGF, the insulin-like growth factor that promote the cell growth. All these factors contribute to the promotion of cell growth, uncontrolled cell growth. The VHL gene mutation, how does it occur? Either by loss of sequences by deletion of this 3p chromosome in the sequences of 12 to 26. 12 to 26, this is the third chromosome, short arm, 3p sequences, 12 to 26. These are the most common sequences that get deleted. And either there can be a translocation between third chromosome to eighth chromosome. This VHL gene gets translocated here or to the 11th chromosome. These are the more common translocations that you encounter in the VHL gene mutation. Or it can be a hypermethylation. The VHL gene gets hypermethylated that leads to its inactivation. Inactivation, it means loss of tumor suppressor gene. The VHL itself acts as a tumor suppressor gene, it gets inactivated. That leads to cancer development. Coming to the clinical features, there's a triad manifestation. RCCs have this triad like this is the RCC. They have hematuria, flank pain, and abdominal mass. This is the classical triad of RCC. Here in the clear cell variant, you find this hematuria, intermittent hematuria, most consistent symptom, and there's flank pain. But here you find this costovertebral pain because of METs to the vertebrae. Most commonly, you find costovertebral pain, and there can be a palpable mass along with pain in the loin. These are the triad manifestations. What are the constitutional symptoms? Constitutional symptoms in general to any cancer. They can all cancer patients they have this cachexic look. Cachexic, cachexia. What are the symptoms of cachexia? Anorexia. He loses his appetite, loss of appetite. Because of loss of appetite, there's loss of weight, and this generalized in general weakness, malaise is present. These are the constitutional symptoms. And also, whenever this clear cell variant it invades the renal vein, and it goes into the vena cava, inferior vena cava, there can be edema of the lower limbs because of obstruction at any level of the IVC. There can be edema of the limbs. And whenever the left renal vein is invaded, it can invade into the left testicular vein also and get it obstructs the left testicular vein. From here, from the kidney tumor, it invades the left renal vein. Left renal vein again, it drains into left testicular vein, where the tumor cells can obstruct the left testicular vein, because of which there can be enlargement of the left testis. It can lead to the left varicocele. Left varicocele. This is the most significant finding. Left varico, I mean, a clinical finding of left varicocele because of obstruction of left testicular vein, because of invasion of left renal vein is characteristic of this renal cell carcinoma. And whenever this renal cell carcinoma, they get metastasized to the pelvic bones or the long bones like femur, There can be pathological fractures. There can be pathological fractures. And coming to the gross examination of the clear cell variant of the kidney, most of these clear cell variants, they are unilateral. 90% of the cases, they are unilateral. They occur in one kidney and they are well circumscribed. See here, it is, you can find tumor in the upper pole of the kidney, but it is well circumscribed and encapsulation can be partially encapsulated. And also, the characteristic most important finding here in the gross examination is the golden yellow color. The clear cell variant are golden yellow color because these are abundantly rich in lipids. Lipids and glycogen are present, but because of abundance of lipids, that is the fats, they are golden yellow in color. This is the most important feature, most important finding of clear cell variant. And also, you can find few areas of hemorrhage and necrosis. Here you can find areas of hemorrhage and hemorrhage. This is the characteristic golden yellow color. And here invasion can be present. This clear cell variant can get invaded into the perirenal fat, the adrenal gland, and renal vein. The renal vein invasion is most important finding because it determines the metastatic potential of the tumor. Metastatic potential of the tumor. Coming to the microscopic findings, so you see here the tumor tissue, normal kidney tissue. When you observe a normal kidney under the microscope, you find tubules and glomeruli like this. But you cannot find any normal kidney tissue here. The entire tissue is like tumorous. It shows you tumor tissue, and the cells are very clear. I mean, you don't find any lot of pink and blue. You can't find here. It's almost like a pale white transparent color you can find. This is the characteristic of clear cell when this is the low power image. And also in between you can find this fibrovascular tissue, the stroma, fibrovascular. Here and there you can find the blood vascular tissue. This is the high magnification view of the microscopic slide. The individual tumor cells, these are large tumor cells and they are polygonal, almost polygonal in size, polygonal in shape. And the nucleus is large, round, and it is centrally placed. The tumor cells are centrally placed here. Tumor cells are centrally placed. The nucleus is centrally placed. Nucleus centrally placed. And coming to the cytoplasm, it is neither eosinophilic, neither basophilic. You can't find any color to the cytoplasm. The cytoplasm is very clear. It is colorless. It is colorless because these cells, they are rich in lipids and glycogen, which because these are rich in glycogen, during the tissue processing formalin, these are washed out. Hence, the cytoplasm is not stained under H&E. You find this pale, clear cytoplasm, hence the name clear cell variant. Coming to the histochemistry, as these cells are rich in glycogen, these stain positive for PAS. Periodic acid shift test is positive because of presence of glycogen and also because of abundant fat. These stain positive for oil redo. Fat stain is the oil redo and the Sudan black. Coming to the immunohistochemistry, all cytokinins are positive, particularly cytokinin 8, 18. 8 and 18 are positive. They are positive for vimentin. They are positive for many other markers like CD1110 and PAX8, PAX2. PAX2 is of abundant importance because PAX2 is the best marker. It has 50 to 80% of sensitivity. Hence, this is the best marker among all the IHC markers. And clear cell variant, not only clear cell variant, all types of RCC, they express paraneoplastic syndromes because the tumor they synthesize ectopic hormones. The ectopic hormones being the renin for hypertension, which cause hypertension, erythropoietin, which increase RBC production leading to polycythemia, and this parathormone like peptide, which cause increase in calcium levels. There can be production of gonadotropins, which lead to feminization or masculinization depending on gender of the patient. And there's ACTH production, which causes Cushing's syndrome. Cushing's syndrome. Coming to the spread of this variant of RCC, it can spread locally to the capsule of the kidney, and to the perirenal fat, the renal vein, IVC, obviously. It can spread easily locally. And the lymphatic spreads are para-aortic lymph nodes. Here the para-aortic lymph nodes, it can spread easily to para-aortic lymph nodes. And whenever, what should I say, the tumor in the kidney spreads to the IVC, it is called a carcinomatous thrombus. Like a clot, it goes from here, it invades the IVC. That is a carcinomatous thrombus. Coming to the distant mets, the most common organ affected is the lungs. Lungs are the most important, most common organ metastasized in clear cell variant, and also it can metastasize in an orderly way. Next is the bone, more common. Next is the liver. Next is skin and brain. Lungs, more important, more common. Next are the bones. Next is the liver. Next is the skin and the brain. Coming to most important grading system, which is common for both clear cell and papillary variants of RCCR. This grading system is called the Fuhrman's grading. Fuhrman's nuclear grading system. In this, the grade 1, it corresponds to the nucleoli, they are absent, or it can be inconspicuous. Inconspicuous means it is not clearly visible, or it can be basophilic, which is a normal finding. At 40x magnification. 40x magnification means 40x objective lens. For example, this is the 40x lens that you use. The magnification that you get is you multiply by 10 to get 400x magnification. If at all you are using this 10x lens, into 10 you get 100x magnification. This is the magnification. So in grade 1, that is a lower grade, that means a safer side, nucleoli can be absent or they're not clearly visible, that is inconspicuous or basophilic at 440x, 400 magnification or 40x lens. Coming to the grade 2, the nucleoli are conspicuous, that means they are visible clearly, and eosinophilic. Eosinophilic nucleoli, it points towards malignancy at 400 magnification. That means 40x lens. When you use a 40x lens, you find it conspicuous and are not prominent at 10x lens. At 10x, they're not visible. When you That means at 40x is higher magnification. Only in higher magnification, these are visible. At lower magnification, the nucleoli are not visible. So somewhat safer side. Coming to the third grade, nucleoli are conspicuous, clearly visible, and eosinophilic at 100x magnification. At 10x, that means 10x length. At the lower magnification, only you are able to find out this nucleoli. So little higher grade. Fourth grade is extreme nuclear pleomorphism, and there can be rhabdoid differentiation or sarcomatoid differentiation. These are the four grades of Fuhrman's nuclear grading system, which are common to both clear cell and the papillary variant. Coming to the staging, stage 1 is when it is confined within the capsule. Within the capsule, if the tumor is confined, that is stage 1. Stage 2, when it invades the surrounding tissue like perirenal fat, adrenal glands, surrounding tissue, local spread, this is stage 2. In stage 3, we have three variants. Stage 3A is invasion into the renal vein or or the IVC. 3B is when it gets invaded into the lymph nodes. When the lymph nodes are involved, that is the 3B. 3B is the lymph nodes. 3A is the renal vein. When both are involved, the vein and lymph nodes both are involved, that is 3C. Vein plus lymph node, that is 3C. Distant mets are the stage 4. The last stage is the distant mets. This is about the staging of RCC. What are the lab findings that you find in an RCC patient? Coming to the first test is hemogram, CBP. You find polycythemia because of this erythropoietin. The paraneoplastic syndrome, we have studied the ectopic hormone erythropoietin, which cause increased RBC production that leads to polycythemia. That finding you have. Coming to the urine examination, you have hematuria. You find RBCs, that is the most common finding. Malignant cells in the urine, this is an uncommon finding. It's an uncommon finding. RBCs is the most consistent finding. When you come to biochemical findings, there is hypercalcemia. Because of parathyroid like peptides, there is hypercalcemia. When you do an imaging studies like ultrasound, you look for the kidneys. Kidneys can grossly show you the tumor. And when you go for bone scan, when you suspect METs, you go for bone scan. This is all about the RCC and the clear cell variant in particular importance. Thank you all.